We know that physiologically something big is happening during menopause and perimenopause. But why has it taken so long for women to get a clinical focus and management support that they deserve? Why has it taken us so long to move away from old models of mismanaging and underrepresenting perimenopausal and menopausal care? That's going to be the meat and potatoes of our presentation series. We're going to take the time to detail out these under-recognized, undertreated, and misrepresented realities of the perimenopause and menopause transition. Our next several slides will look at the historical lack of clinical focus and management support for menopausal women and really note that it stems from several interconnected failures within the research community, within the medical education community, and within the cultural landscape. We're going to identify that there are current gaps that are rooted in historical oversight and not just patient complexity. Now, we'll dive into each one of these individual areas, but these are some of the key reasons why menopausal symptoms have been overlooked historically. First and foremost, there is a historical gender bias and an underfunding in women's research. This includes a conversation about NIH excluding women from studies up into a more recent date. It also individualizes that cardiovascular and neurologic research has largely been male-focused. We'll talk through cultural minimization as well as defining cultural minimization of midlife women's health. This is simply the concept that symptoms have been normalized as just aging or psychological or all in a patient's head. Our focus with menopause has truly been on fertility, not on these symptom clusters. There was a tremendous overcorrection of data that was misrepresented in a Women's Health Initiative study that was launched in 2002. We'll slow down with a few slides and really discuss that study as it was a key moment of underprescribing for many clinicians. And last but not least, we'll talk about the concept of fragmentation of care and condition identification rather than thinking holistically about perimenopause and menopause as a neuroendocrine transition. Let's first start out with the concept of cultural minimization. What this means is that over the last several decades, social and cultural narratives have really historically dismissed or downplayed the importance of menopause. And midlife health concerns have been framed as just aging or really just something that women should endure. Some examples of this cultural minimization include hot flashes and mood changes, really treated as jokes or trivial complaints, that cognitive changes like brain fog have been dismissed as just normal stress or age-related, and that sexual health changes are often ignored or stigmatized rather than understood and treated. This minimization has led to underfunding of research, lack of clinician training, and reduced access to care for millions of women. It also has reinforced the stigma and leaves women without the clinical focus or management support they need and deserve. As we mentioned earlier, that misrepresentation and minimization led to a severe underfunding and underrecognition of menopause and menopausal consequences. We have tremendous knowledge gaps that persist in elucidating the genetic, biologic, and environmental factors that do indeed influence the onset of menopause and symptom presentation. There's also gaps in menopause research. These are not surprising. There are gender biases in federal funding that are still not reconciled today. This helps us understand why menopause, which is a condition that primarily affects women, is under-researched and underfunded. And even though 100% of women living into late life will experience menopause, it's not considered one of the 292 listed topics in the National Institute of Health Research Portfolio online reporting tools. If it's not recognized, it's not going to be funded and it's not going to be researched. We can see that the data on this slide really represents a mismatch in what is researched and what is experienced. Women's participation in clinical trials does not consistently match the actual burden of disease. In some critical fields, especially neurology, endocrinology, and cardiology, women are significantly underrepresented as research participants, despite higher rates of disability and disease impact. This mismatch has contributed to gaps in evidence and delays in diagnosis and treatments that may not reflect a woman's real-world experience. When women aren't equally represented in trials, the evidence guiding their care becomes incomplete and biased by omission. Even where women bear the greatest disease impact, specifically in cardiology as well as neurocognitive concerns, the evidence guiding their care really is built on someone else's physiology. Perhaps one of the biggest gaps and gaffes in research was the data that was produced in 2002 by the Women's Health Initiative. This study started in 1993 as a randomized controlled trial to evaluate the effectiveness of a variety of hormone replacement therapies and how those therapies could impact chronic disease in individuals over 60, female individuals over 60. However, in 2002, after about 9 years, the WHI study arm that had patients taking a specific type of estrogen and progestin was abruptly stopped. We'll talk about the study in more nuance in the next couple slides. What I want to point out, however, are the differences in what the WHI was investigating versus how hormonal therapies are now currently utilized. The average age for an individual participant in the WHI study was above 63. This means this study did not take a look at individuals in their 40s or the perimenopausal age range at all. The focus of the study was on chronic disease. It was not on ameliorating individual symptoms. The hormone types, the actual prescriptions that were utilized, do not compare to the prescriptions that are utilized today, and we'll detail that out in upcoming slides. Last but not least, we have the concept of risk calculation. We'll dive deeper into the concept of absolute risk and relative risk in just a few slides, but it really comes down to the nuances within the research study and how the media jumped on inappropriate numbers to report, inducing fear and really causing quite a lot of alarm. Overall, we built 20 years of fear on one misapplied study. Millions of women ended up discontinuing their hormonal therapy abruptly in 2003 due to these alarming headlines. This slide helps us understand the timeline of the WHI study and the data. The take-home message is in the purple box. There was a 2-decade, 20-year gap in research. This is incredible. Let's slow down and add in a few more details. This slide shows us our accurate timeline that highlights the magnitude of the impact from the misrepresentation of the WHI data. What we can see here is that the study initiated in 1993, but in 2002 and again in 2004, multiple arms of this study were stopped due to a miscalculation or an over-reporting of relative risk versus absolute risk. This ended up leading to decades of lost care, fear from patients and clinicians, mistrust of medical information, as well as misinformation as provided by the media. Now, I also want to slow down and highlight that I was part of the physician class that was dramatically impacted by this news and really went through medical school in fear of prescribing hormones. I matriculated to naturopathic medical school in the very early 2000s, right as this news was hitting the media. I was afraid to prescribe hormones for nearly 2 decades because of how the media misrepresented this information. We'll talk a little bit more in depth about how that data was misrepresented. And as we launch in, let me take a minute to explain what absolute risk is versus relative risk. Relative risk is a comparison between 2 different groups within a study. It compares how much higher or lower the risk is between 2 groups. That's different than absolute risk. Absolute risk shows us the actual difference in event rates. The WHI original publication emphasized relative risks. These risks did not adequately contextualize the absolute risk, which was very low for participants. Approximately only one additional case of breast cancer as compared to 1,000 women taking the intervention. Because of the inflation of the relative risk and the promotion by the media of those numbers, it led to an exaggerated perception of harm, especially among younger, recently menopausal women whose baseline for adverse risk was much lower. This misinterpretation stemmed from a variety of factors. Again, we've already discussed the WHI average age was around 63. All of the results, even though they were misconstrued, were generalized to a all-inclusive postmenopausal population, and the media and professional communities failed to distinguish between relative and absolute risk. This led to a tremendous impact on millions of women. Women were denied or discontinued hormone therapy by their providers, even when their symptoms warranted therapy. A generation of clinicians, including myself, avoided using hormone replacement therapy or created a larger gap in supportive care. Our non-hormonal treatments became the default, but even these fell to the wayside. Research directions absolutely shifted away from hormone therapy and delayed nuanced investigations into timing, formulation, and individualized risk assessment. This global societal narrative reinforced the idea that menopause is a condition to be endured rather than a life stage that could be treated and supported. And it's only in the past decade that we've started to begin to shift our focus back into appropriate prescribing, really targeting individual, safer, bioidentical approaches. Ultimately, the misconstruing of the information within the WHI led to increased rates of untreated menopausal symptoms and possibly higher rates of osteoporotic fractures. There was a large cost of fear, and that cost was women's health and women's agency. We'll take this slide to do a little bit of myth busting. For those of you that are just now getting more educated around the myths of the WHI, use this slide to feel more comfortable in your hormonal prescribing and hormonal prescription referrals. Myth number 1 is that hormones are unsafe for all women. I truly believe this throughout my first decade of practice. The fact is that the risks in the WHI were linked to older women. Again, that average age was 63, not the mid-40s, and they were on a very different blend of hormones, which we'll discuss in just a few slides. Myth number 2 is that estrogen causes breast cancer. The fact is that in one branch of the study, individuals that were not taking progestin, there was no increase in breast cancer and even a slight reduction. This risk signal came from a specific progestin, and that's a synthetic progestin, which is very different than we use today. Myth number 3 is that hormone therapy increased heart attack and stroke risk for everyone. What's the real fact is that timing matters. Starting hormones within 10 years of the onset of menopause or before the age of 60 appears neutral or beneficial as compared to detrimental. And last but not least, myth number 4, the WHI proves that hormones should be avoided. The WHI studied outdated formulations, and we'll see the changes and the nuances of how these formulations were outdated. Ultimately, it's summarizing or understanding these key myths and correcting them for yourself and for your patients, which will lead to better menopause care and outcomes. So this data misrepresentation also led, as I've nuanced, to a clinician knowledge gap. Ultimately, medical schools don't cover much in regards to menopause. As a reminder, every single woman that's going to live into older age will experience menopause. So it's really an atrocity that medical schools, some don't even get more than 3 hours of menopause training. In a study of internal medicine and family doctors, only 6.8% felt prepared to manage menopausal symptoms, and 20% did not receive any teaching during residency. That's led to a tremendous fragmentation of care, where patients are sent out to specialists rather than thought of holistically. This clinician ignorance isn't just neglect, it's actually been curricular omission from educational practices. Let's focus on this idea of fragmentation of care just a little bit longer. What it means is that in healthcare, menopause is often broken down or isolated into symptoms rather than being thought of as a holistic whole body transition. Some examples of this are a patient newly experiencing arrhythmias. They'll probably get referred to a cardiologist to treat those arrhythmias rather than a hormonal assessment. Individuals with sleep quality issues, these are going to be managed as insomnia rather than progesterone withdrawal. And vaginal dryness, this is a top key genitourinary concern. This is often only handled in gynecology rather than with the primary care physician. Why this matters. This fragmentation of care misses the big picture. Menopause is a systemic hormonal transition, not just a collection of unrelated problems. When we don't take the time to integrate all of this information, women end up bouncing between specialists and receive conflicting information and often don't have a team approach to their care. When the care fragments, the patient kind of disappears and gets bounced between all of those specialists. Part of our goal, as I've mentioned previously, is to really present menopause as not a collection of conditions. It's truly a unified transition. We're going to start to move more into what can we do now. And the first step is education. We can step in, we can step up, we can support our patients, and we can educate ourselves as well as our patients or clients.
Start your 7-day free trial at KarazianInstitute.com if you're a licensed healthcare practitioner ready to evolve your functional medicine practice. Explore over 300 hours of clinical training, masterclasses with leading functional medicine clinicians, and certification pathways. Or check out the Academy of Functional Nutrition and Lifestyle Medicine at afnlm.com. Whether you're on the path to certification as a functional nutritionist or simply want to optimize your own and your family's health, our skill-building approach builds real-world competence from the ground up. And lastly, if you're dealing with chronic health challenges, visit drknews.com for self-paced courses that help you understand and address fatigue, brain fog, autoimmune conditions, gut problems, and more using evidence-based approaches. The content on this podcast is for educational purposes only and is not intended to diagnose, treat, cure, or prevent any disease. Always consult with your healthcare provider before making any changes to your health regimen. Thanks for listening, and don't forget to subscribe and share with someone who might benefit.